so that's why about a year and a half ago I set up this group HEATED, which stands for Huntington's Equal Access to Effective Drugs. And it's pretty much, it's a group of the EHDN, but it's also, I think, a banner for a campaign, really, to be honest. So now I'm just going to go to next slide. Oh, there we go. So here we go. So like all good campaigns, we have to have a slogan. So that's, what do we want? We want equal access to drugs against HD for, or effective drugs for anyone who would benefit from them. And when do we want it? We want it as soon as these drugs are licensed by the appropriate bodies. So it's not a very catchy campaign slogan, but that's really, that's what we're about. That's what I'm about, really, is to do that. So these are the great set of problems to have. We've got to look at all these things, and then obviously we've got the chairs and the presidents of HDAs around Europe. So this is aimed at you guys and also at the patients and the families. So these are the tasks we have, really. We've got to work out how many people might benefit from any of the new treatments that are coming along. And that's a harder question than you might imagine. We've got to look at this magical thing called cost per quality adjusted life year. That's the metric that most health organizations use to work out whether they're going to pay for the drugs or not. We've got to look at our ability as a health system to deliver drugs, particularly non-oral drugs like intrathecal or intracerebral drugs. And we've got to say, you know, if those drugs turned up, they were licensed, let's say in 2 or 3 years time, which is possible, the first of those, you know, do we have the capacity to even deliver them to people? And then we've got to really identify what are the barriers to access and how could we overcome them. And then the crunch question is, who makes the decisions? How do they make the decisions? And how can we influence them?
And I'm just interrupting you because it's really important. DMT.
Oh, sorry. Disease modifying therapies. Sorry. Yeah. Disease modifying therapies. And at the end of, I'm going to do a little bit on each section, maybe only a couple of minutes on each section. And then at the end of it, I'm going to put, what should the HD community do? These are my suggestions for the HD community. And at the end, I'm going to say, okay, in order to do those things, what is the HD community going to stop doing? That's a big challenge, but it's a painful fact, I think. Okay, so the first question is, how common is HD? Because we've got to know how many people are out there with HD if we're going to work out how many people are going to need treatment. As it turns out, this is a much more complicated problem than you might imagine. So in the end, we've had a series of meetings about this, and it turns out the word HD means all sorts of different things to different people. And here are a few definitions. So here, this is a big list of ways you might divide people up into HD and not HD. And you can see, depending on your definition, I'm not going to read them all out, and the numbers are really different. I'm going to point to this one here, which is the second to the bottom one, which is those who meet the criteria for a specific clinical trial or other licensed indication. That might be the definition of HD, for instance, that health paying organizations might use. They might say, we're only going to consider giving it to people who would be roughly the same as the sorts of people who are in clinical trials. Well, we know that's nothing like the number of people who could potentially benefit from the, particularly, you know, treatments that target RNA or DNA. And so in a way, what we might be interested in is more like this one, much further up the scale, which is those people whose brains have changed somehow as a result of the gene expansion and before brain cells have died. So it might, so that would be a lot earlier, and there'd be a lot more of them. So it might be that we're already into an argument about how we define who might, you know, how many people there are might depend on how we define the condition in the first place. So I guess the lesson from this is there's no such thing as HD or not HD. It depends what you mean by HD. But paying organizations might mean a different thing to what we mean as a community. So we need to be all over that argument and start to think about whether or not we should be advocating more for those people, the people who've got changed brains, but may not necessarily be very symptomatic or even obviously symptomatic at all. So what should the Huntington's community do? You're going to see this slide a lot. So I guess the first thing we need to do is to understand these issues and educate ourselves and our constituencies about these issues, and then start identifying the policymakers about which of the groups they think are going to be eligible for this treatment. And also, I think we have to advocate on behalf of those people who we think might benefit from treatments, but who might not be considered eligible by health organisations. So, you know, I'm sure Hugh will tell us about this in relation to SMA type 1 and type 2 and the arguments that have been happening there, because they mirror what we're going to experience probably in 3 years from now. So the next thing is how best to measure quality adjusted life years, and the thing about cost per QALY. So I hope people are reasonably familiar with quality adjusted life years. That means it's a metric which measures how much longer you would expect to live, and also how much better quality of life you'd have as a result of the treatment. So it's a sort of equation which mixes those two things together. So there's a simple equation for this. Cost per quality adjusted life year. You take the cost of the new treatment, subtract the cost of the existing treatment, which maybe you might stop. Then you look at the quality adjusted life years that the new treatment might give you, subtract the quality adjusted life years of the old treatment, put one on top of the other, and then you get the wonderful solution, cost per quality adjusted life year. So it sounds really simple, doesn't it? But within all this equation, there's much complication and much room for argument. So if we take the cost thing to start with, so I decided, in the absence of any information, to guess how much the Roche treatment, the intrathecal treatment, would cost. So after much pressing of calculator buttons, I made a complete guess of this amount per person per year. Might be wrong, and this is the upper. There's a wide confidence interval. Might be this much, might be only be this much, and that's largely going to depend on how well the phase 3 pivotal trial goes at the moment of the intrathecal drug. But however, like all good radio advertisements, this comes with a very large rider and qualifier, which I'm not going to read it all out to you, but it's basically, I don't really know. This is a complete guess based on other drugs, maybe Spinraza a little bit, based on the fact that all the negotiations about price are pretty much behind closed doors. Certainly in the UK, these are negotiations between pharma companies and governments and health providers. And even the figure that we see in the books is not the real figure. So it's all done behind closed doors. And so I guess in the absence of information, people like me are going to guess. And that's probably got me into a bit of trouble sometimes, and certainly created a few shockwaves. But I'm going to keep guessing and until I get more information from the people who make decisions. So just to give you a flavour of how much this is, 180,000 euros. I did a bit of a calculation. I reckon this is a Tomahawk cruise missile. It's about that much of a Tomahawk cruise missile. So depending on how you feel about the value of Tomahawk cruise missiles, this is either a complete bargain or a utter rip-off. Depends how you feel about the missiles, really. Just to give you a flavour of it. Okay, but it's not just about the cost of the drug. This is also the cost of giving the drug, particularly if it's an intrathecal drug, because you need somebody to stick the needle in, and you need a bed, and you need a nurse, and you need a pharmacist, and a bunch of things. So I'm going to guess there's that bit of cost, but then there's a whole bunch of other potential costs and cost offsets, including, you know, delay in admission to nursing homes, specialist nursing care, change, you know, lost or gained tax contributions to people who have dropped out of work, changes in what benefits you'd received. Also, a big one for me, I think, is opportunity costs for children, because we all know that it's very common for children to perhaps drop out of school in their teenage years to look after mum or dad, or certainly get disrupted schooling and disrupted education. And there may be savings or other costs on other therapies. So not all health systems work this way. Many health deciding systems, for instance, in the UK, we have NICE. Pretty much at the moment, just look at this. They don't look at any of this at all, unless only as a sort of contextualizing bit of information. They don't factor this into hard economics. It's really this that they look at, and we might want to change that, because this could be a big, you know, if you could delay nursing home specialist nursing home admission for instance, 5 years, that could be a huge cost saving. And so I think we have to start making sure that these are on the table and understand these in terms of our negotiations. Okay, so what should the HD community do? You see, this is a difficult thing. There are a lot of jobs, a real lot of jobs. So we've got to understand and challenge the financial models for these new drugs, really understand what the financial models are and who's making those decisions. For instance, in the UK, we have NICE, but in many other countries, there are all sorts of other equivalents. And we've got to get to the heart of those discussions. Who's making those decisions based on what information, and do we accept it, or are we going to challenge it? Okay, next, measuring quality of life. I just want to introduce you to this quality of life measure called the EQ5D, which the E stands for Europe, so it's Europe-wide. This is the standard measure that most health-paying organisations use for deciding whether a drug is good or not. You give this to the patient and you ask them to fill it in. Now you tell me, if you have any knowledge of Huntington's at all, do you think this is going to be a really good representation of whether a drug or a therapy really helps a person with HD, especially if you ask them to fill it in beyond a certain stage? I mean, I can go into the science of it if you like, but I think you can see that this is not fit for purpose at all. But right now, certainly in the UK, and I would reckon most of Europe as well, this is what your health paying organisations will be using to decide whether or not a drug is going to be funded or not, in terms of measuring what a change it makes to somebody's quality of life. So it's possible, I guess the danger here is, you might get a drug that works really well, because you've got, because of the nature of this scale, it might turn out that it doesn't look like it improves quality of life at all. In which case an organisation who's paying might say, well, we're not paying for that because it doesn't really work. And so that's a massive, to me, that's really, really worrying. And at the moment, nobody's doing anything about it. What should the HD community do? First of all, understand this issue. Second of all, I think HDAs and patients and their relatives need to be challenging the scientific community about this, because I think we've done really badly, because we've got a scientific community that's full of molecular biologists, and molecular biology is very exciting for doctors on the whole and other researchers, and working on rating scales is regarded as not very sexy and quite boring, to be honest, and nobody wants to do it. I mean, there are people out there, but we don't have many of them in our community. And so I think as a scientific community, we failed you right now. So you need to be calling us out on that and saying you failed us, you need to do better. Then finally, we've got to find out who's making decisions based on this data and start, interacting with them and challenging them. And I'm not saying that's all on you. It's, that's the scientific community and the patients and anybody who cares really to get involved in that discussion. But right now, to me, that's a really big problem. Okay, I'm loading you with problems here. As I say, they're good problems to have. So let's say we had an intrathecal therapy, which we may well have in 2 or 3 years' time. What's our capacity to deliver them? So even if it gets licensed and somebody's agreed to pay for it and you rock up at your hospital, the answer is right now there's no capacity to deliver it, or very, very limited capacity. This is something that Jean-Marc Burgunder, the ex-president of the HDN, presented last year. Even in super specialist centres, only 3 out of 27 could even give any more than drug to any more than half of the people who might be eligible. So that tells you that's a huge gap. And the reason for that is that neurologists don't have many intrathecal therapies right now, so they're not used to giving it. There's no infrastructure right now in most places. And I reckon in my region, which is 4 million people, we're looking at somewhere between, if the intrathecal therapy anyway, somewhere between 3 and 10 treatments per working day, every year, for as long as that therapy is viable. So that's no mean feat. That means that might be, at least 2 probably permanent beds in a hospital to do that for a region of 4 million people. That's a guess. So it depends on all sorts of things, but I'm just giving you the scale of it. So what should the HD community do? Well, we need to find out this information, and we need to start interacting probably fairly early with health systems and saying, okay, this is coming your way, intrathecal therapy is coming your way. Now, I guess Hugh will say something about this in relation to SMA, because that's also an intrathecal treatment, and it's a harder one to give because they're children and they tend to have more sort of curly spines on the whole, so it's even harder in a way for them, but there's a lot fewer of them. So I'm really interested to see what Hugh has to say about that. So I'm getting to the end now. This is a picture of the tsunami, the Indonesian and the Indian Ocean tsunami, which was, oh gosh, 2011 maybe? I forget now, the one on Boxing Day. And I feel like, or I have felt until recently, a bit like this person here, who's sort of pointing at the tsunami and going, look everybody, there's a massive tsunami coming. And then I felt like, well, different people have, some people are running away from it right now. Some people like this person here are just sort of walking along the beach having a look and not really apparently concerned at all. And, you know, we've got a bit of time. Hugh will probably tell you about SMA. They got rather surprised early because their trials were stopped early because of the efficacy that was proven. So they were taken a bit more by surprise than we were, I think. But we've got some time now, not very much time, maybe 2 or 3 years before the first of these tsunamis comes. And we've got to be prepared because it's going to be hard. So the plan of action, my suggested plan of action is my second last slide. I think firstly, we've got to lead and educate and mobilize our whole community, including our patients and their relatives, and also the youth organizations and people who are well enough to pick up the challenge, because there's plenty of people out there who want the challenge and they need guidance and need education and they need resources. We've got to look locally, nationally, internationally at what the barriers might be, because they might be different in different places. And you know, you've just got to work out who makes the decisions, who has the checkbook, and how we're going to develop our relations with them early to tell them that this is coming. We also have some shared interests with pharma companies, because we want effective drugs going to our people and they want effective drugs to sell. And so we're having to start to develop more and more our relationships with pharma companies, but that's not easy because we have a lot of potential conflicts too. So it's about how do we work constructively, but in a very boundaried and professional way with pharma companies who have money and resources and they want to sell their drugs, you know, and do a business. I understand that. And they've invested a lot of money. So we have some allied interests and some conflicts of interests, but we can't just not work with them. I think we do have to work with them, but we have to learn how to work with them in a very canny way. And, you know, I'm already in that situation with some companies who I don't want to name, who, you know, they're tough people and they're hard to work with, but we need to be in the room with them. And we have more strength than we think we do, because they're on limited timescales and their products might have limited timescales. So they really need us and they need us quickly. So we do have leverage with them, which I've noticed more recently. So we have to understand and leverage that for what it's worth. And then the final difficult question is, we have to look at our own structures as organizations, because we've evolved quite rightly to be care organizations predominantly, and we're going to need to develop a political dimension. And that creates tensions within boards, I think, and it creates tensions in systems because it means changing our organizations, I think. And when we change, if, you know, I just showed you how many new tasks there are there. That means as organizations in countries and internationally, we've got to decide on some things that we might have to stop doing in order to do that, and have some really difficult decisions to make. I feel like we have to do this because I've seen, and one of the options is, I've seen this in other areas like Duchenne muscular dystrophy, for instance, is that organizations didn't change and they stuck to their guns and said, we're going to be care organizations first and foremost, And what happened then in one or two places is that then splinter groups form of people who say this is acceptable, we need to have a more political dimension and a more, we need to dedicate more resources to this, and the organisations haven't changed fast enough, so we're going to set up separate organisations. And that's happened in muscular dystrophy. And I think, that might be okay. It might be okay for your organisation, but you've got to think about, is that a really good way forward? I'm not sure whether it is. I honestly don't know. But these are the challenges that we face, which is about how we're going to allocate our resources. Whew. Like I say, really good problems to have, fantastic problems to have, but difficult problems too. So I'm going to leave you with the words of Dr. Ambedkar, who was regarded as the father of the modern Indian nation, who was involved with basically campaigning against colonialization. And I know decolonializing things is all the rage at the moment, but this is his phrase that he first coined: educate, agitate, organize. I don't think he meant agitate like necessarily getting out on the streets agitating. It's more like stirring things up and really thinking about things carefully. So I guess we have a responsibility to our community to do these things now, and to do them now before, I don't want to do them the day the treatments get licensed and everybody says, where are my treatments? And we have to say, you can't have them yet because of all the barriers that we knew about and we didn't do anything about. So that's me. I'm done now. Thank you very much, everybody.